Hello.
Hi, my name is Joanna and I'm a nurse practitioner student. I'm going to be doing a head, eyes, ears, nose, throat examination on you today. We're going to be actually recording this and uploading it on YouTube. Is that okay?
Yes, it's okay.
What's your name?
Anais.
Anais. Hi, Anais. My name is Joanna. So when we start by the head, eyes, ears, nose, and throat exam, we're going to start by doing the inspecting your hair distribution and also your scalp. So I've already washed my hands and we're going to be starting with the inspection, okay? So when we inspect, we're making sure that there's even hair distribution and that there isn't any balding noted. Then after inspecting, we're going to start palpating, and we're palpating to make sure that there's no hematoma, no lesions or cysts noted. And then we're also going to palpate the occiput to make sure that there isn't any depression noted. So after we inspect and palpate the scalp, we're going to be moving on to the face, make sure that there is symmetrical, that there isn't any crusting in the eyebrows, and that the eyes are symmetrical as well. Now I'm going to be touching your eyes. Now we're going to be lifting the eyes and making sure that there isn't any ptosis or no exophthalmos noted, and the eyelids are, there's even hair distribution as well, no crusting in the eyebrows or in the eyelids. Meanwhile, we're doing that, we're also inspecting the cornea, the iris, and the sclera, making sure that it's white and that there is no abnormal growths or any discharge noted or lesions or foreign bodies noted. When we put the eyes down, we're going to be checking the conjunctiva, and we're going to be checking that it's pink, that it's not pale. Pink is normal and that's what we want, and that there isn't any lesions noted as well. After we do that, the inspecting part, we're going to be doing a visual acuity, okay? By any chance, do you wear glasses?
No.
Okay, so we're going to be using a pocket guide. With the pocket guide, I'm going to just have you face this way a little. With the pocket guide, we want to be 6 feet apart from the patient. So for this video, so I can still be in frame, I'm gonna be like right here. So I'm gonna ask you to, if you can please cover your right eye and tell me, can you read what is right here?
CFDHJ.
Okay, and can you leave it covered? Can you read this?
LTFZH.
Okay, can you cover the other eye? Can you read this?
CFDHJ.
Okay, can you read this one?
No.
Okay, and now uncovered, can you read this?
CFDHJ.
Can you read this one?
LTFPH.
Okay, so the patient was able to, the left eye and right eye were 20/25 and both eyes was 20/20. And we would document each eye separately in our documentation. So now we would move on to do the, I'm gonna be using the otoscope's light to check for the light on the patient's eye. So I'm gonna be checking directly for the patient to make sure that the eyes, the pupils are constricting. So if you can just look at me, so that eye constricts. Then we're gonna be checking the other eye. That eye constricts as well. Now for consensual constriction, we're actually gonna be checking the opposite eye when I shine the light. So we're gonna be checking the patient's left eye and making sure that the other eye constricts. And then for this one, we're going to be checking that the other eye constricts as well. Okay, and both eyes constrict. Now we're going to be moving on to the, we're going to be moving on to the extraocular movement. So for this, I just need you to like look at my finger and don't move your head, just follow my finger. So I'm going to start by testing the cranial nerves, the 3, 4, and 6. So we're going to go up, and then lateral, down, up, lateral, down, and making sure that the patient doesn't have any nystagmus when we're doing this examination. After that, we're gonna be doing the convergence test. And for that one, we're just gonna be, you're gonna look at my finger and make sure that it's making sure that it's converging to the middle. And now we're gonna be doing the, I need you to cover one eye. And we're going to do the wiggle test. So we're gonna cover the same eye. And we're gonna, from the back of the patient, we're gonna, tell me when you can see the finger. You see it?
No. No.
Okay.
No.
Okay, now cover the other eye. And then tell me when you can see the finger.
No. No. No.
Okay. Now for both eyes, tell me when you can see the finger.
No. No. No.
Okay. So after that, we're making sure that the eye is able to see confrontation. Then we're going to be doing the accommodation. So I need you to look at my finger. Now, can you look at the back? And making sure that the eyes are accommodating, so pupils are equal to reactive to light and accommodation. When the patient is able to, their pupil dilates when they're looking far, it means they're accommodating to a different, to look farsighted. Then on to that, we're going to be moving on to the ophthalmic examination, the eye examination. So we're going to start by setting our ophthalmoscope to 0. Turn on the light. And now, since I'm gonna be looking at the patient's right eye, I want to be looking with my right eye as well. So to prevent any any bumping of the head or anything. And then I'm gonna get the thumb of my finger and anchor it on the patient's eyebrow to use as a landmark, and put my finger out to make sure that I don't bump heads with the patient. I don't know if for purposes, can you move your head just a little more so they can see? We're gonna be identifying the red reflex of the eye. Okay, and then once we have it, we're gonna be zooming in. Okay, and then we're going to be looking at the optic disc. The optic disc should be a 2:3 ratio. It should have a clear margin, and the arteries, we're going to follow them. Make sure that there's no AV making or cotton wools, and that there is, the macular disc is identified as well. Sorry if I'm too close. Okay. Then we're going to do the same for this procedure before I mentioned, sorry, but we would actually dim the lights to be able to visualize the red light reflex better. So we can shut off the lights, and we're going to be, now with this one I would do the left eye to left eye. So we're going to be doing identify the red light reflex, which would be orange, yellow. Sorry. And then we're going to be going in and zooming in once we identify. And we're going to be looking for the 2:3 ratio, as mentioned, sharp margins, and follow the veins. And make sure that there isn't any cupping or nicking when we're examining. So that would be the the eye examination, sorry. Now we would move on to the nose. So we would inspect the nose from the outside, make sure that there isn't no deviation, there's no deviated septum, there isn't any discharge. We're gonna be palpating the frontal sinuses and the maxillary sinuses to make sure that there isn't any tenderness. Do you have any tenderness, Anais?
No.
So this would be a sign of sinusitis if the patient does have tenderness. We are going to be using the otoscope, to examine the turbinates. So we would be changing this, and when we examine the turbinates, we want to make sure that there is no
that there isn't any redness or swelling, and that it is patent. There isn't any, sorry, is it bothering you?
No.
That there isn't any, there's good airflow.
Then we're going to be examining the other one as well.
Okay.
So it's, and now I'm going to be asking, can you occlude one of your nares? Breathe out. Okay, can you occlude the other nares? Breathe out. Okay, so we would say the patient has good airflow in both nares, and then I'm going to ask you to smell something, okay? Tell me if you can smell it.
Yes.
Okay, what does it smell like?
Oregano.
Okay, so we could change it up and we could test the other nares as well by changing it to something different. After we do that, we're gonna be checking the ears from the outside, making sure that the outer ears, that there isn't any, there like no redness, no discharge coming out from the outer ears. Then we're gonna palpate the ears. So I'm actually gonna pull a little on the pinna, sorry, and tell me if there's any tenderness.
No.
And I'm gonna press on the tragus. Any tenderness?
No.
If there would be any tenderness, it would mean it could be a possible indicative of a patient having an otitis media or an otitis externa, depending on where it would hurt. So we're gonna be moving on to the gross test of the ears, and for this, it's gonna be testing different types of the hearing loss. So I'm gonna have you cover your left ear. And I'm gonna stand 2 feet behind from the patient, and I'm gonna ask the patient, I'm gonna whisper to the patient 2-syllable words and ask her if she can repeat those words after me.
Apple.
Okay, and then cover the other.
Baseball.
So she was able to hear she was able to hear the words that I whispered to her. So now I'm gonna be using the tuning fork, and the tuning fork, we're actually gonna be doing 2 different tests. The first test that we're gonna be performing is the Weber test. The Weber test is usually used for the sensory neural hearing loss. So for this, I'm gonna put it in the top of her head, and let me know when you stop hearing the vibration, okay?
Now.
Were you able to hear it on both sides or one side less?
I heard it on both sides.
So if the patient is able to hear it on both sides of vibration, that would mean that there's lateralization to both sides. If it would be unilateral, then that would mean that there is a hearing loss on one of the sides. The second test that we would be performing is the Rhines test. For the Rhines test, we're checking to make sure that the conductive hearing. So we're gonna be placing the tuning fork first on the mastoid process and have the patient tell us when they can't hear the vibration anymore, and then place it on the front of the ear and have them tell us when they can't hear the vibration anymore. So
Now. Now.
So this would be air conduction is greater than bone conduction, which is a normal finding when we do the Rhines test. So we're going to be performing the same exam and the same in the other ear.
Now. Now.
So air conduction is greater than bone conduction. Then we're actually going to go to the more invasive part of the ear examination, and we're going to be examining the tympanic membrane. So we're going to start off with the right ear. In the right ear, when we examine an adult patient, we're going to actually pull the pinna up and back, and we're going to, sorry, let me light this up. We're going to be going into the ear and checking the tympanic membrane and the internal canal, making sure that there isn't any redness noted. And we're gonna be, we're gonna be checking to make sure that the tympanic membrane is pearly gray, that the cone of light is a 5 o'clock position, and that there isn't any bulging or erythema noted.
and we are able to see the head of the malleolus and the umbo. And then on the left ear, we're going to be doing the same procedure as well and checking the tympanic membrane. And we're going to be checking to see that that it is pearly gray, and that the cone of light on this side is 7 o'clock position, and the head of the malleolus is visible, and a numble as well, with no erythema or redness noted, and no bulging, which is going to be a sign of an infection as well. So now we're going to be moving on to the mouth. With the mouth, we're going to be starting with inspecting the mouth, making sure that there isn't any ulcers, no lacerations, that the lips are moist and not chapped. We're going to have you open your mouth nice, and I'll be checking the buccal mucosa, making sure that there isn't any canker sores, no redness, no abnormal growths. Then I'm going to be checking the patient's gingiva, making sure that it's pink, no bleeding, no lesions, no hemorrhages noted, and then we're going to be checking the teeth, the dentition, making sure that the patient doesn't have any cavities, no abscesses noted. Now I'm going to have you, can you stick out your tongue? All completely? Okay, so we're going to be checking the papillae, make sure that there isn't no exudate, which could be indicative of thrush, and then that it's pink as well, not a red color. Now I'm gonna have you move your tongue to the left and move your tongue to the right. Now can you move it against this? Okay, the other side? Okay. And then I'm gonna have you open your mouth, and I'm gonna have you, can you say ah? Ah. I'm inspecting the soft palate with this, and I need a little light, so I'm gonna use the light of this, and ah. So when I'm inspecting the soft palate, and also inspecting the uvula rise when the patient says ah. And then meanwhile I'm doing that, I'm also checking the posterior pharynx, making sure that there isn't any exudate or redness or any streaking indicative of like a viral infection or anything, or an infection overall. And then I'm also grading the tonsils. If the tonsils are visible, it would be a 1+ grade in the tonsils, since they are visible. If they would be touching, that would be a grade 4, which would be indicative of tonsillitis. So now we're going to be moving on to the neck. For the neck, I'm looking at my equipment, sorry. For the neck, I'm just going to be looking for the patient, making sure that the neck is supple, symmetrical, that there isn't any asymmetry noted. We're going to be asking the patient to flex, hyperextend, and then can you do the lateral? And the other side, can you shrug? And now I'm gonna have you, can you, against resistance, push against my hand? Okay, against resistance, push against my hand. Okay, so that would be checking the spinal accessories muscle as well. So after that, we would be checking the lymph nodes on the patient. So we're gonna start by checking the periauricular lymph nodes, and then we're gonna go to posterior auricular lymph nodes. Then we're going to do anterior cervical lymph nodes, and then go to posterior cervical lymph nodes. It would be a nice massage for the patient. Then we're going to be going to the occiput or occipital, and we're looking to make sure that there isn't any nodules that are non-tender, which would be a sign of infection. If they're fixed or matted, it could be a sign of malignancy. And then we're going to be going to the submandibular, and then submental, and then we're going to go to the supraclavicular, and then infraclavicular, and we're checking the trachea to be midline, which is what is expected. We don't want a deviation in the trachea. So now the last part of the exam would be checking the thyroid. For this one, can you face the camera nice? So in the tangential view, we would want to make sure that there isn't any goiter noted, that the thyroid is not enlarged. For testing, we're gonna pretend the patient has, we're just gonna ask her to swallow, but you can also do this, offer the patient a glass of water meanwhile you're testing the patient for the thyroid. So for the thyroid, we're gonna start by feeling the first bone, which is the thyroid cartilage. Then we're gonna go and feel the second one, which is a cricoid cartilage. Then under that, we're gonna feel the 2 rings of the trachea, and then this below the right there is gonna be the thyroid. The thyroid, we're gonna kind of, if it's uncomfortable, let me know, okay, nice? We're gonna be asking the patient to swallow and make sure that there isn't any asymmetry when we're holding the patient, that not one side is going higher than the other side. Now I'm gonna push with my right hand the thyroid a little to the side and make sure that there isn't any nodules palpated or any enlargement noted on one side. And then we're gonna push it to the right side and palpate the same. And we would expect the thyroid to not be enlarged. So this actually concludes our head, eyes, ears, nose, throat exam, and neck as well. Thank you guys for watching, and see you guys until next time.